Thank you very much, Mary. It's great to be here and see so many friends in the audience. So I'd like to use this time to kind of give an overview of how the world and the kind of the research community is approaching global cancer issues. I think there was for some time a misperception that cancer was a disease affecting the rich countries. Now that we're beginning to gather data more accurately, we know that more than 60% of cancers occur in low and middle income countries. And this is true for other chronic diseases, heart disease, diabetes, etc. So what I wanted to do in the talk today is to go over where we stand in terms of UN and World Health Organization and World Bank priorities for cancer and non-communicable diseases. Some just discussion of the U.S. Work in cancer research, particularly in light of this new moonshot announced by President Obama. Discussion of kind of what NCI and our center is doing, as well as finish up by talking about some potential areas for collaboration, as well as some of the work that we've already been doing together for a long time. So this was the issue of non-communicable diseases and cancer was something that was brought to the global high-level discussions by Sir George Allen, who is from Trinidad and Tobago. He was director of the Pan American Health Organization, which is one of the regional WHO organizations, and he really pushed the UN to convene a high-level meeting on NCDs in 2011. This was only the second high-level meeting on a health topic. They'd had one on HIV 10 years before. And the UN charged the World Health Organization with developing a plan for addressing this. And the World Health Organization convened a number of meetings, and the World Health Assembly endorsed what they're calling an action plan for the prevention and control of non-communicable diseases in 2013. And there's going to be follow-up meetings at the UN in 2016 and 2017 to ask countries to report on how they're doing. In addition, the World Bank has always, or for many years, had an effort to try to see what the best buys for disease control are. These were initially published in one slim book, which apparently inspired Bill Gates to get involved in the health issue of addressing the world. The second edition grew to 3 books, and I think in one of those books there was a chapter on cancer. More recently, it's grown to 10 volumes, and so there's a separate book on cancer, there's a separate book on surgery, and other books that will be coming out later this year. I think the surgery and cancer books were the first ones to come out. There have also been a number of global blue ribbon commissions, including the Global Task Force on Radiotherapy for Cancer, which Mary helped spearhead. A number of people in this room worked very hard on. A variety of Lancet commissions, which address this issue. Investing in health, more focused on how it's important for countries in the developing world to put appropriate resources into health. Women in health, global surgery, and one's underway now in palliative care and non-communicable diseases in what they're calling the bottom billion. And I think all these reports lay out both what we know, what we need to know, what needs to be done to implement based on the evidence base. In terms of what the WHO Action Plan has set up, they, to a certain degree, pulled out of the air a proposal to say, well, let's see if we can get a 25% reduction in premature mortality from non-communicable diseases, defined as deaths before age 60, by the year 2025. And you can see here the goals: decrease blood pressure, decrease tobacco smoking, decrease physical activity. They weren't all that cheerful about whether they'd be able to reduce diabetes and obesity, but they hoped that it wouldn't grow, reduce salt intake, reduce alcohol intake, increase access to essential medicines and technologies for 80% of the population. And this drug therapy and counseling is for people at high risk for stroke and myocardial infarction. So they recommended the countries set up a monitoring framework that included cancer registries, death registries, looking at various risk factors here, looking at what they called national systems response. Slide is a little bit difficult to read, and so this is kind of the summary here. Recommending, as I said, cancer registries, death registries, tracking risk factors, physical inactivity, tobacco use, rates of obesity and overweight. And in terms of national systems response, vaccines for HBV and HPV, cervical cancer screening, access to essential medicines and technologies, and access to palliative care. So these are the recommendations, and each country has to report each year on how they're doing addressing these issues. At the UN General Assembly last year, it was, I think, in September, they endorsed what are called the Sustainable Development Goals, which replaced the Millennium Development Goals. There was a lot of debate. Do we have too many goals, too few goals? And you see here, goal number 3, which is with the Band-Aid and the syringe, is good health. I'll briefly review what that includes, because you see a number, and you'll see a number of the kind of the sub-goals are relevant for cancer and non-communicable diseases. First, reduce maternal mortality, reduce deaths of newborns and children under age 5, attack AIDS, TB, malaria, and hepatitis, which I've highlighted in red the things that I think have relevance for those of us who think about cancer and NCDs. They, again, pulling kind of a number out of the air that was nice and round. They said, well, rather than 25% by the year 2025, we'll go for 30% by year 2030. Again, not based on a whole lot of modeling data, but it's nice round numbers. So that was something people could remember. Prevention of narcotic abuse and harmful use of alcohol, which will obviously help us with transmission of hepatitis and cancers linked to alcohol. Decreasing road deaths and injuries, increasing reproductive health services. And I think these things have relevance because we can build breast health programs on top of reproductive health services. We can build HPV screening into those services. And obviously, if we want to have surgery for cancer care, we need a system that includes surgery, anesthesia, clinical laboratory services in general. Achieve universal health coverage, substantially reduce deaths and illnesses from hazardous chemicals, pollution, which we know are causes of many cancers. Strengthen the implementation of the World Framework Convention on Tobacco Control, and it's one of my favorite ads. 20,679 physicians say luckies are less irritating, or whatever. It's really impressive that when you look at the history of how they co-opted the medical community into promoting cigarettes. Support research and development of vaccines and medicines for communicable and non-communicable diseases, access to medicines for all. Health financing and recruitment, development, training, and retention of the workforce in developing countries, and strengthen the capacity of all countries in health surveillance. So I think we, from the NCD community, tried to monitor the progress to make sure that what the recommendations were coming through were appropriate for cancer and NCDs. It was really at too high a level for us to have much input into very specific cancer targets, but I think we can certainly live with these sustainable development goals. Now, last month, when President Obama was giving his State of the Union address, he turned around, and this is the very moment when he turned around and pointed to Vice President Biden and said that he wanted Vice President Biden to lead a moonshot to cure cancer. This was news to Vice President Biden. And we have since been involved, shall we say, with this internal U.S. government working group to try to figure out what to do. It's not as though we have new money. There's some talk that they're going to take some of our existing money and then give it back to us and call it new money. So we're still unclear whether there's going to be new money for this. But at least there's attention to cancer. Now, obviously, this is not the first time that we've seen high-level attention in the United States to cancer. You all may recall the war on cancer, and this is indeed President Nixon signing the legislation, which was called the War on Cancer legislation back in 1971. This is just sort of from a civics class who we are. We're part of essentially our equivalent of the Ministry of Health. We're a sister institute of the Centers for Disease Control at FDA. At NIH, our budget is about $30 billion, of which half go to the three biggest institutes: National Institute on Allergy and Infectious Disease, National Heart, Lung, and Blood Institute, and our National Cancer Institute. All three of our institutes have budgets of about $5 billion a year. And as everybody in this room knows, we fund research across the scope of cancer. And one of the things that I hope to make clear to you today is how we're trying to strengthen all these areas with concern for the global aspects of cancer. As Mary mentioned, our director, Harold Varmus, when he came back to NCI, and I should note that he was director of the U.S. NIH for 6 years, then went off to run Memorial Sloan Kettering Cancer Center, then came back to join us, had as one of his high priorities strengthening the work that we were doing globally in cancer, and created the center that I now run. And so the goals of our center are to help coordinate and stimulate global cancer research across the U.S. NCI and NIH. We certainly don't do all the research, and there's been a lot going on way before our center was founded. For example, we've been working in China on cancer issues for 35 years, so we have a long track record. We're trying to work on translating those research results into policy and global healthcare practice consistent with the Sustainable Development Goals that you saw. We want to strengthen research in what I'm calling region-associated cancers, so cancers that we don't see a lot in North America and so may not necessarily have studied a lot. Strengthen the development of resource-appropriate cancer diagnosis and care, and I'll talk a little bit more about that. As well as, from our stakeholder meetings, our discussions, trying to build a global cancer research community. So I have two deputies who many of you may know, Lisa Stevens and Thomas Gross, who's a pediatric oncologist. We have now 29 full-time equivalents, which we're very thankful to Dr. Varmus and his successor, Dr. Lowy, for supporting the growth of our center. And these are we have very good people focused on the regions around the world. Preetha is based in India. Jack is based in Madagascar. Some junior people based in Europe and Argentina. You see the thematic leads that we have: NCDs, pathology, clinical trials, cancer control planning, epi, health surveillance, health diplomacy. So I think we've got a good team. As I mentioned, we're trying to build on the research that we have done relevant for global health. A lot of it has been focused on the link between chronic infections and cancer. And what we've learned is that probably somewhere in the range of 20 to 25% of cancers in the developing world are associated with chronic infection, which is a different pattern than we see in North America and Europe. And here the worst actors are HPV, hepatitis B and C, and Helicobacter, as well as a variety of some other infections including EBV, HIV, HDLV1, liver flukes, schistosomes. These are areas that we consider high priorities for research. In terms of HBV, we've been jointly studying both cholangiocarcinoma and liver cancer in Thailand. About a year ago, we had a delegation from Mongolia come to see us to say, here in Mongolia, we have the highest rates of hepatitis B and C in the world, and therefore the highest rates of liver failure and liver cancer in the world. So they wanted to ask NIH and US CDC for technical assistance, not money, but just advice on how to deal with prevention and screening. And they engineered it or negotiated a deal with Gilead to get the new hepatitis C meds for $800 a course rather than $80,000 a course. And so we subsequently organized a site visit that included NCI, two other NIH divisions, CDC, the regional WHO office, and folks from our cancer centers, as well as Korea, Japan, China, to help us better understand the problem, identify the areas that needed more research, start to think about how to roll out Hep C, screening for Hep B and Hep C, treatment for hepatitis, for both of the hepatitides. In terms of HPV, we're also working with the Gates Foundation, both on screening as well as trying to establish a lower cost or lower number of doses needed for the HPV vaccination. We're planning a definitive phase 3 trial comparing 1 versus 2 doses of the currently available vaccines. I think it's probably going to be the nonavalent Merck vaccine and the 2-valent Glaxo vaccine. And then as I mentioned, we have we have a low-cost technology program, which again I'll mention a little bit later, but this does include validation studies of 2 different cryotherapy devices for treatment of pre-invasive cervical cancer in low-resource settings. This is the Affordable Cancer Technologies program I mentioned. This is a new program. We went to our advisory board and said, we've identified a gap. There's nobody really putting money out to do validation studies of new technology. We still have a lot of programs that fund the prototypes of new devices, but really there weren't any good funding sources for the actual validation studies in low resource settings. So we were able, with their permission, to earmark somewhere in the range of $30 to $50 million over 5 years to validate new technologies. Our first round has been funded. So we made 7 awards, and you can see the types of things we're funding. Activities for the treatment of oral cancer, diagnosis and treatment of pre-invasive cervical cancer, including the 2 different cryotherapy devices I mentioned, diagnosis of hepatitis C, and detection and diagnosis of breast masses. We're about to announce the second round of awards, and the third round, I think, are in review at present. Going back to tobacco, this is another picture I discovered. This is our President Reagan here saying, "I'm sending Chesterfields to all my friends. That's the best Christmas present anyone could want." And as many of you know, they've named the new hospital at UCLA after President Reagan. So one of the issues that I think is important to note is that this framework convention, which was the first global treaty on health, was largely based on research that NIH had sponsored. And we at NIH, NCI, Heart, Lung, and Blood, Fogarty continue to be the largest single funders of tobacco control research in the country. So it has been signed by 168 countries, legally binding in 178. 2 countries in the world have not signed it. Can anyone in this room identify those 2 countries? Yep, U.S. is correct. What's the other country? Indonesia is the other country that's not signed. So we try to abide by it, but we have not signed. So we do fund a lot of tobacco control research, as I said, through our partners at other NIH institutes. We have a partnership with the U.S. FDA, which uses some of the, now that they have regulatory authority over tobacco, so we have what's called a regulatory science program. We co-sponsor these global and regional conferences called Tobacco or Health, and we also help fund and help organize the meetings of the Society for Research on Nicotine and Tobacco. I mentioned, this is another area where we're trying to stimulate research, looking at the use of betel quid and areca nut, which is common really across South Asia, East Asia. But we really don't know much about the mechanisms of areca nut carcinogenesis, about the addictive properties. Sometimes it's used with tobacco, sometimes it's not. We don't really understand how the influence of tobacco, concurrent alcohol use, as well as the areca nut contributes to the risk of oral cancer. So we've got this meeting coming up with partners you see here, including our National Institute of Dental and Craniofacial Research, University of Malaya, MD Anderson, and as well as a variety of other partners helping us plan this conference. Another thing I wanted to talk about is our International Cancer Control Partnership. This is something that we developed with the help of the International Union for Cancer Control. We realized that there were a lot of players in the field that were willing to help countries with develop national cancer control plans and provide technical assistance, but they were often working at cross purposes and certainly were not talking to one another. So we built a kind of a joint website that countries can go to see the templates for national cancer control planning, to look at case studies, to look at how countries have implemented the various pieces of this. And we've organized regional workshops. We've inviting countries to send delegations of about 6 to 8 people, representatives from ministries of health, from civil society, from academia, to evaluate how they were doing in terms of national cancer control plans, looking at other people in the region, and exchanging best practices. So you can see the sites where we've had these meetings, and we're going to have a follow-up meeting for Southeast Asia and the Pacific Islands later this month, or next month in Singapore, and we're going to have one focused on Central America over the summer. Another thing we're really working hard with is how we can strengthen the work of our cancer centers. As many of you know, we have more than 50, actually I think it's 68 at the last count, NCI designated cancer centers in the United States. 60 of them do clinical and translational research, 8 do basic only. And when our center was founded, we realized that we didn't have a handle on what the cancer centers were doing. We asked them to tell us, and we were bowled over by what they were doing. But it was also clear that even within an individual center, there seemed to be something of a lack of strategic focus. The surgeons might be working here, the pediatric oncologist working in another country, the medical oncologist working in a third country. So we wanted to figure out how best we could help them focus their activity. There were some good examples of cancer centers that worked with other schools at their own university. Duke, for example, has got a global health team that includes their cancer center, their schools of nursing and engineering and medicine. But again, that was more the exception. We also heard that it was hard for junior faculty to get protected time to do global health research. And we certainly heard that it was a lot harder to set up clinical research outside one's own country. It just took a lot longer. And so in 2013 and 2015, we issued competitive supplements for our cancer centers, which I think helped with that career development, as well as helped build on some of the investments the cancer centers had already made. We also have added global health as an approved track for cancer centers. Our cancer centers have to come in for peer review every 5 years. You can say, we want to, have our breast cancer program, our prostate cancer program, our lung cancer program partially supported by our core grant. And now you can add global health as one of those programs that are potentially supported by your core NCI grant. And in reaction to the kind of our consternation at looking at all the great work cancer centers doing, we realized that we did need to have a map so we could see who was working where. And so we have since put together this map. We launched it last year with at the Consortium of University of Global Health Programs, and we worked with a group of young faculty members at Harvard who helped us with the design. We tried to get ASCO and UICC on board to make sure that their data fed into this. And we think it's a really good way for both individuals, cancer centers, to look and see where their people are working, but also to see who else is working in the same country. Another project that we've just undertaken is to see if we can build on, or to help build consortia of universities from high-income countries to work together in countries or regions. And there's some good examples of that, such as the AMPATH partnership that the University of Toronto participates in, where a group of North American universities all work together in partnership with Moi University in Eldoret in Kenya. But there are a lot of kind of negative examples. When, for example, we looked in the country of Ghana, and to see which of our cancer centers were working there. And we identified 6 U.S. cancer centers working in Ghana. And as far as we could tell, they were not talking to one another. And then we reached out to our friends in the UK and said, can you look in your database and see which of the British universities are working in Ghana? And they found 20 British universities working on cancer in Ghana, not talking to one another and not talking to our university. So we said, well, this is probably not a good thing. And so we put together this funding proposal to help coalesce consortia of universities to work together in a region or country. We didn't want it unique or specific to cancer because we thought some of the cores would have relevance for other diseases, but we did want to focus on NCDs because there is clearly there's money set aside for HIV and TB and malaria, but not a whole lot of money set aside for cancer and NCDs. So we're starting with planning grants. We've had I think we had 39 applications come in for these 2-year planning grants for the first receipt date, which was in September. There's a second receipt date in July. And we've opened it so any university from around the world can apply for this. We've built in a broad definition of NCD, so it includes mental health, it includes trauma, hematology, palliative care, $200,000 per year for 2 years, because it is just to kind of do an assessment of what's needed in that area, build a consortium. And so we're excited about the applications that are coming in. We've got, I think, about 15 coming in that want to do cancer and 30 that want to do cancer and cardiovascular disease. I think another 15 want to do cancer and diabetes, obesity. So we're excited about the interest. We developed this funding opportunity announcement with input from other NIH institutes, and we're going to ask them for co-sponsoring the planning grants. And then we plan to follow up with to actually build these centers. We're still trying to figure out the budget, but it will probably be about $1 million a year, we think. And we also are going to be asking other countries to help fund the participation of their universities in the relevant consortium. And so we've, I think there's interest. I mean, we certainly in talking to Australia, for example, they said, well, we've decided to focus our development aid in Southeast Asia. Well, that's fine. Maybe we can work together in Indonesia or Burma. And so we hope to have those discussions with Canada, with China, and some of the other countries you see listed here. I want to finish up just by talking about some of our ongoing, very productive collaborations between Canada and the U.S., and then some thoughts about where we might work together on global health. We have, as you all probably know, a very close partnership with investigator-initiated research. Investigators from Canada have the highest success rate of any country outside the U.S. in terms of getting support for R01 funded research. We've also had a very good partnership in clinical trials, both in early phase drug development trials, largely led at Princess Margaret and in Ontario, but also in phase 3 clinical trials. NCI has helped provide core funding to the NCI Canada Clinical Trials Group, now called the Canadian Cancer Trials Group, since its inception in 1980. In addition, Canadian institutions were among the founding members of what is now the Children's Oncology Group, the RTOG, the NSABP. None of our of what we call our National Clinical Trials Network components really would have existed without that input from our colleagues in Canada. We have been very pleased to have full partnership with Canada in what was the International Cancer Genome Consortium, and that's now morphed into the Global Alliance for Genomics and Health. And I think one of the leaders in this has been Tom Hudson at the Ontario Institute for Cancer Research. We would, I think, welcome greater partnership in cancer control planning and implementation. We're working with sick kids, for example, on seeing what we can do to improve access to early diagnosis and access to care for pediatric cancer in the Caribbean. And I know there are many Canadian universities working in Africa, and we'd sort of like to see if we can team up more closely. Mary has been the president of the International Union for Cancer Control, and so we have been delighted to be able to work with the strong Canadian delegation to UICC on a variety of projects. We are trying to push the what's called the Asia Pacific Economic Collaboration Forum, or APEC, to develop more activities related to HPV and cervical cancer, and so we are delighted to have Canadian help with those efforts. I mentioned the tobacco control research. This is obviously a critical piece. We and Cancer Research UK are trying to create a global group of research funders that will kind of do joint and parallel research on tobacco control. I mentioned a little bit in talking about our cancer centers of how we're trying to strengthen their commitment to global health research, and this is something that we would love to do more closely with Canada. As I mentioned, we would like to see some potential co-sponsorship of our Centers of Excellence program, building on that AMPATH model with MOI. So I'm going to finish here because I'd like to hear your comments and answer your questions. Here's our contact information and our Twitter feeds. So thank you.